first one is joint loading. So I wanted to go back to the beginning. And Hatcher probably is one of the folks whose name will pop up a lot when you start doing lit searches on joint loading, because he actually kind of was the person who started using mathematical modeling to look at joint loading. And so this is the original paper where he actually developed the original mathematical model, and then lots and lots and lots of scientists since then have used that mathematical model or their version of it to try to assess joint loading based on occlusal contacts, position of muscles, strength of muscles, all sorts of stuff. And for me, one of the premises is that joint loading is something I need to think about, depending upon where the disc is, depending upon how that patient can load tissues other than the disc in function or in intercuspal position. I actually may need to alter the tooth contacts in order to keep them from being uncomfortable to alter joint load. So I kind of have to know how those things work. So that's one of my thought processes. So we'll just look at some of the basic science behind this. So this I thought was a nice study, and what it basically looked at is joint loading, working side versus balancing side during normal function, during chewing. So they actually did that really fun thing. Everybody is familiar with Lundin and Gibbs' study on mandibular movement. This was similar, so they put boluses of food between people's teeth with lots of electrodes and all sorts of stuff hooked up to them and had them chew. But what they actually did was then they recorded those movements and then used Hatcher's mathematical model of joint loading to then layer on how is the joint loaded during normal function. And so what they came up with, I'm sure this is going to be just shocking to everyone, is that joint loading is actually greater on the balancing side during normal strokes of normal function than it is on the working side. Okay? So, and then that study got repeated, and this is Hatcher again, so now Hatcher's back in the fray. And what he actually did was he didn't want to look at function, because his thing really, if you go back and look at all of his literature, is he really was interested in parafunctional activity. So a lot of his studies look at clenching, grinding, weird mandibular positions. And so he did that same study, repeated it, except instead of doing normal function, what he said is, let's look at clenching. Let's look at it in intercuspal position. Let's look at it when they have their teeth out to an excursion, so it's unilateral clenching, and see how that affects joint loading. Okay? And so, again, what he found is that joint load is greater on the balancing side, under a clench, no food in the mouth, when there's unilateral contact on the working side. And he actually did, the part of this that I thought was really sort of interesting, is he looked at it not only in an excursive movement, so actually go out to the right and be only on the right and now clench, but he also looked at it for patients who had their teeth in intercuspal position but didn't have unilateral equal contacts, equal number or location or intensity of contacts right and left of the midline. So that part was really interesting. And one of the things for me that I found that in that research is that he sort of postulated from his research that people who have teeth that are infra-occluded will actually load the joint on the side where they've got the teeth infra-occluded more than on the other side if they happen to be prone to clenching. So if they actually statically clench in intercuspal position, that side is going to take more joint load.
What about the value of the load of functional versus parafunctional?
Say more. I'm not sure I understand your question.
In other words, the amount of load that you can create on a joint in parafunction, I would speculate, would be significantly higher than you would in function.
I think we can put those pieces together, because we're going to talk about the literature on force application, like muscle engagement. And I agree with you, but I think you have to overlap the literature. Unfortunately, I didn't find a study that sort of looked at both of those things.
Because patients that have severe parafunction are the real danger patients. I mean, and that's just something I think that's genetically innate. I mean, I have 4 kids, and 2 of them, when they're, little, and you can walk past the room and you can hear the teeth grinding like marbles.
Right.
And then 2 don't. And it's just certain people have that and some people don't. And you can adjust the teeth and equilibrate and restore all you want. That's who they are. Mm-hmm. It's just personality type, or that's what they do.
Right.
And, that's part of, when you start looking at the cases, I try to select that out before I even look at the tooth, just to see where they're going to be. But I think the more the joint loading issues are occurring in the parafunction during function.
Yeah, you know what?
It's not really, it's an issue, but it's not an issue because there's a bolus of food to something there. You're not loading at the same force level.
Yeah, you know what? I guess I would say I agree with that from a theoretical perspective. And then the other thing I would say is I have patients who one of their chief complaints is pain on function. So they have a lateral pole disc displacement; it doesn't reduce, and where they notice the discomfort is during eating.
That's after the issue has occurred. I'm saying it's just a matter of what's causing the pain. It's like what's causing the accident.
Right.
It's like two cars ran into each other. The result is
the result is
this is the result. But it's something. It's what impact if you loaded the joint at 400 or 500 pounds per square inch on the occlusal versus 150. Well, that 450 is what's going to cause that joint to really cause damage, where the 150,
Well, let's get nitpicky. If the joint loading is vertical...
that wasn't nitpicky.
No.
That wasn't. That was, yeah, are you kidding?
Very nitpicky. If the joint loading is vertical versus posterior, that's important.
Mm-hmm.
And so typically in a vertical capsulitis, where the capsulitis is superior or maybe posterior, if you have that patient chew on the same side, supporting what you said, they feel better because they're closing that gap with food. Therefore, functioning with food, they may not be as much pain unless they chew over here because they're trying to avoid it. So
that's why they tend to say, "This hurts," but I chew on the other side. Well, that's great. That's making it worse.
Right.
Exactly.
So then the other idea is, what if the load is actually on the lateral collateral ligament because their really source of pain is constantly grinding on this side, which is doing this there.
Exactly.
Then that's a different joint loading that you're going to use some other thing